A very good evening to all of you. It's my pleasure and honor to be part of this meeting. So here are we today focusing on the contemporary updates from EASD, which has just been recently concluded exactly, I would say, 24 hours back. I would like to thank each one of you for your humble presence at short notice and helping us to bring the science from ESG forward. We have with us Dr. Amya Joshi sir from Bombay, Dr. K.M. Prasanna sir from Bangalore, Dr. Purushottam Chatterjee from Calcutta, and Dr. Madhukar Rai from Varanasi. We all know Dr. Prasanna Kumar, one of the senior most endocrinologists of the country, well revered with a lot of research publications and known for his oration and thoughtful skills in terms of putting science forward. Some of his reflections, very contemporary evidences, uh, clinically relevant, yet dynamic with respect to the global published evidences. We have with us also Dr. Purushottam Chatterjee, sir from Calcutta, uh, dynamic not just with respect to his clinical acumen, but also from his recent publications. For example, a very nice publication which categorizes different SGLT2s based on the mortality perspectives. Which component, for example, I remember reading this article which says that dapagliflozin perhaps is responsible for better all-cause mortality. Segregation of the MACE and the outcomes based on the individual SGLT2. Another interesting article is the lipid profile in patient. A very warm welcome to you, sir. We have with us Dr. Madhukar Rai from BHU, known for his research, managing such humongous patient load consistently for so many years, keeping the thinking hat on with managing extraordinary patient expectations. Some of his research perspectives in the global arena, putting India on a global map of publication. A very warm welcome to you, sir, as well. We have with us Dr. Amya Joshi from Bombay, astute clinician. He's at Bhaktivedanta Hospital in Bombay, and one of the revered works which has been cited so well with a good citation index in last decade and consistently on several publications, making again a footprint as far as the Indian mark, as far as the global evidences are concerned. So, with the due permission of the panelists, let me kickstart a discussion with respect to some of the newer updates. Yesterday, we have seen the release of the new consensus document, ADA ESD consensus document. We'll focus on this and then subsequently move on to some of the research elements encompassing unbiased high opinion perspectives across the varied spectrum of the publications which have come through, presentations which have come through, and one of the important element is we all know that ESD is perhaps one of the most revered and respected forums for the difficulty of the papers to be accepted. Number one, quality and the diversity of the sessions, the didactic lectures we know of. So that's what ESD started. There were approximately just 800 papers that were accepted. Not a very high number, I would say. So the thresholds are getting difficult and difficult. Perhaps that's the reason the quality of science should and perhaps should improve as well. So we'll begin the discussion with the guideline perspective. I'll just quickly run through it. We already know it. It's already there in the public domain. First of all, guidelines, rapid evolution in recent past, perhaps in last 10 years, if we see, the rapidity of the guidelines has been perhaps annual or a biannual affair. The reasons, the glimpses will tell us the reasons as well into hindsight of it. So one important element, that it perhaps looks into a very holistic perspective, takes into account the contemporary evidences in last 3 years, more or so, keeping the pace with the innovation in diabetes science, social determinants of health and systems, and equality of care. This arena, perhaps, if we connect with the science and the recommendations, how well and how strong it fits into our own country, that's going to be a point of discussion. Beyond doubt, something which has been reinforced from the earlier versions as well, holistic person-centered care. No MBPT, no doubt. Even RSSGI has been a strong proponent on that front. Indian perspectives, the wheel concept, a different reflection, I would say. Greater focus on weight goals as an essential component. We are perhaps drifting, I don't know, drifting would be an appropriate word, or moving towards non-HbA1c related targets gradually. That's an important area of discussion in the meeting today. And also the consolidation of evidence from CVOTs. Yesteryears, there was a time when CVOTs were considered controversial, should have been redundant. There have been critics of that. And here is a time that consensus statement is looking forward into the consolidated evidences from CVOTs. So that's perhaps the change, what SGLT2 has forcibly perhaps made us to learn that CVOTs cannot be ignored for sure. One important element is the person-centric care as far as the diabetes management is concerned. Access key person characteristics, some of the snapshots, what's being recommended, consider specific factors that impact choice of treatment. We'll not get into the detail of that, but certainly overall the objective is prevention of complication and optimizing the quality of life. Theoretically looks very pleasing, but perhaps I believe that in our country maybe not easy to implicate so easily. So they give the entire details, step by step, section by section, how to approach, how to evolve around that domain. Very interestingly, choosing therapies as far as weight management is concerned, especially what's being recommended is set individualized weight management goals and consider regime with high and very high dual glucose efficacy and weight efficacy. So weight efficacy perhaps is a new dimension, a new vocabulary perhaps would be very strongly taken up beyond these guidelines. Let us see how things evolve in the forthcoming ACE guidelines in the month and this year. So 5S, the exercise, the strengthening, sweating, sleep, good quality sleep, and the sitting. So this is a comprehensive approach which is being reflected. The entire 24-hour behavior is important. They have broken out into each and every component across the spectrum. So let us begin the discussion on this front. Your comments, your suggestions. Is it the same perspectives, put it in a different domain? Implications, importance of this, realistic. Open for the panelists to guide us on that.
Thank you. First of all, we should realize guideline is a guideline. Guideline is not a law. And when guidelines are made, that the whole world or general population are taking into consideration. And guidelines are made depending upon the evidence. You have level of evidence A, B, C, D, and all that. When you look at evidence, first thing is, everything in guidelines is not based on level A. Maybe 30, 40, not more than 40% of the facts, recommendations which are given are based on level A. More than 60% is not level A. That means randomized clinical trial. Then what is B? Maybe meta-analysis. What is C? What is D? And it's a patient practice. So guidelines are not Bhagavad Gita, Quran, or anything. You should remember. Second thing is, if there is one guidelines, why you have 20 guidelines? Everybody has access to same guidelines. Why different guidelines say different thing? The fact is same. So depending upon the people involved, they take. Next thing is, whatever international guidelines, there should be national guidelines like RSSD. Then endocrine society, we say, many of these things are not applicable, not practical, not feasible also. So that is why when it comes to translation, you have national guidelines and say, these things are not socially, politically, economically, regionally, or culturally not acceptable. You can make changes. So that is how you should view guidelines before going to detail. But you showed a second line, we said, ultimately what does ADA, EASD guidelines say? Discuss with the patient, have individualization. It is patient choice, no longer doctor choice. I discuss it, patient agrees, yes, I can afford GLP-1, I cannot afford. We agree that you have to do these tests, either affordable, accessible, available, adaptable. Sorry, sir, neither acceptable, nor adaptable, nor available, nor affordable. That's why everybody is listening here should remember that guidelines are not the ultimate. We are also responsible for guidelines for the last 3.5 decades. So with this view, we should always discuss rather than telling it's a sacrosanctum, word by word, verbatim it is possible. No, neither possible nor it can be implicated. This is my view.
Very well, sir. Very well. Thank you, sir. Comment from the other esteemed panelists. Uh, Dr. Purushottam, sir, Dr. Madhukar, sir, Dr. Ramya Joshi, sir.
So, thank you. My comment is that first I fully agree with Dr. Prasanna Kumar regarding guidelines. And secondly, considering the recent ADA EASD guidelines, I think the most important thing that attracted in their thought about the 24-hour cycle as far as this diabetes is concerned. So it is not only hyperglycemia, but this vision also helps us to go through the other comorbidities. So it can help in managing other important comorbidities. It's very common in diabetic patients. Again, probably in much more common in our society. And whatever the areas I have gone through this consensus report, what I thought is most important, and I feel it is very important for our patients, is the lifestyle, like quality of sleep, what is the exercise, what should be the diet, proper diet. There are no clear pictures in previous, whatever, even in other guidelines also, what should be the diet, what should be the exercise. There is a vague thing, there is a very little, still we don't have proper hard data, but still we can see a silver lining as far as these parts are concerned. Because what I feel in a diabetic patient, or rather a patient with a lot of metabolic problem, if you don't change your lifestyle, it is not that the available medicines like what is it, GLP-1 or GLP-1 analogs and GLP-2 inhibitors is not going to help in long run. So it's a good thing to do. And for India, I do feel that change in lifestyle management can help a lot. This is my view.
Very well, sir.
I think what I would say is that guidelines can be, changing every few years. And we know that something that was standard of care may not remain a standard of care after 10 years.
Yes, sir.
But they serve as a very good guiding principle for diabetic treatment stakeholders, maybe from general practitioners to physicians to endocrinologists, to start a discussion with the patient that, okay, this is what is a common recommendation. This is what is an expert recommendation that you are supposed to follow. And there could always be individualizations. And in that, I think there are a lot of things in the guidelines which have, I would say, after looking at the 5S yesterday, I also felt that, okay, this is good simplification of messages that we want to convey. Like rather than doing prolonged exercise, which is desirable, if you don't want to do that, they have not been dictative. Okay, you have to follow this, follow this, follow this. No, if you cannot sweat, it's okay. Reduce your sitting time. I have been emphasizing my patients to focus on something called as non-exercise activity thermogenesis. Count your steps at the end of the day. If you have not done that, do it in the end at the night. On 10th day, patient realizes that he has to make his quota complete. So obviously, he makes sure that from the beginning of the day, he takes some more steps every day. And obviously, sleep. If you exercise many times, it helps in sleep also. We cannot buy because if you take a few simple examples, we all 4 experts are from different parts of India, and I'm sure a simple question like what time your patient returns home, especially if he's working, will be different in all four perspectives. But maybe a common frame of mind with which you imbibe these thoughts on your patients. And I think that has came well in these guidelines.
Very well, sir.
And for me, if how I take these guidelines, am I audible?
Yes, sir. Yes, sir. Very well, sir.
Yes.
Basically, what I presume is that gives an opportunity for those to get a collated view from dedicated experts in that particular area, who give you the perspective on what is new in that particular thing and which is incorporated into the existing guidelines and something which is excluded. Now, it gives us, one is a legitimacy. If you are prescribing something, it gives you a legitimacy, statutory thing that you are doing no harm, at least so far the available evidence. And because the first thing which we always look at if you are prescribing a new molecule is, or a new perspective is, you are doing no harm. So that gives an excellent sort of a dossier on which we can step up and put forward our perspective. And then based on the drugs records on the glucose lowering, the organ protection and other things. And vis-a-vis what are the different comorbidities which are available in the patient. And of course, Dr. Prasanna has very rightly pointed out that the resources, the availability, the patient education, and all these things, and how much the patient can imbibe, and patient psyche, all these things are very, very important in formulating a management strategy for a particular patient. And of course, these guidelines, they always come handy. And we have changed guidelines continuously being like evolving. And I was really, when we used to see the ADA guidelines way back in the like 2 decades back, see how primitive they were. Although we are practicing entirely a different sort of medicine. We were practicing a patient-centered approach. Indian doctors were very smart in that. And now they have come down to that, because there the insurance and the other thing will always like the doctors to stick to the reimbursement issues, and all these things are there. Unfortunately for us in India, this is not the perspective. But of course, the patient, pocket, availability and acceptability of the patient, and most importantly, what the patient will get out of the treatment is to be re-emphasized, because the patient is only bothered about certain numbers. And education is a very, very important component which has to be. So this guideline, which is evolving and coming up, it gives me an idea, and it gives a statutory stamp to the practice if you are doing practice on those, based on those guidelines.
Very well, very well. In fact, sir, I mean, you rightly said, now the Western world at least is talking on the personalized approach. But, if you look into our own setting, I don't think so. It's a rocket science or something which may not be even required to document. They have documented well, but it's an unsaid rule. Perhaps that's the reason we manage expectations, patient loads, so and so forth, and still achieve that to a certain extent the desirable outcomes. So let me just quickly, take through the snapshot. We know metformin, the journey of metformin, US, India. US for substantial duration of time did not accept as a relevant molecule. I think the wheel is turning to a certain extent, a good circle, I would say. Perhaps the directions has been that metformin may not be the best choice, at least when SGLT2s are there. This could be a point of debate, prospective correlation from the emerging evidences. Who knows if metformin, if US FDA had maintained its CVOT long time back, may or may not be. We don't know. We can't say that how metformin would have fared in that direction. But certainly, yes, the focus and direction, there is a tilt and a drift toward SGLT2 inhibitors in that regard with GLP-1. I will discuss that, or we'll seek your opinion, perspectives on that. Sulfonylureas perhaps get a little backseat in terms of the perceived or the hypoglycemia. heterogeneous group across the variety of sulfonylureas what we know of. TZDs, Indian context may be different from the Western world. This is again a debatable issue. We see that every forum, this is the dictum that this has to be a topic of debate. DPP4 inhibitors, yes, the focus has been reinforced with respect to combination therapy, including specifically vildagliptin focus. Durability is a very strong phenomena. We know that 4-year, 7-year, 10-year data, which is there with a combination of DPP4 inhibitors, vildagliptin, metformin, so on and so forth. SGLT2, I think this has led to a very strong comprehensive science. Whether we love it, whether we hate it, the evidences are so overwhelming that beyond HbA1c, it has, definitely it has gone overboard. Who knew, in terms of 2014-15, when these agents just came up, the direction dimensions would rapidly change, and the confidence on the need for CVOT, that debate has stopped now. There is a certain element which is clear that CVOTs have demonstrated across the spectrum, be it cardiovascular, renal, so on and so forth. GLP-1, I would say quite a substantial data has been presented at the recent EASD as well, and of course, consistent evidences. Western world has started looking towards combination therapies. I think we have been much ahead of time, practicality, and we don't have the patent issue at a broader spectrum in our own country. Western world cannot combine A plus B because until A or B simultaneously gets off patent, at least one, they cannot club it. So perhaps the evidences were not in that direction. Simple, what we have been communicating earlier, we know of, well documented, put it into a consensus statement. Achievement of glycemic control, I think that's the gradient, the grade what they have postulated in terms of the choice based on the efficacy, very high, intermediate, glucose lowering implications across the spectrum of molecules. The dual incretins is another focus which has emerged this year at EASD as far as documentation, the quantum and the depth of data is concerned with newer molecules. One important element perhaps is that SGLT2s may not be focused exclusively on ASCVD as a starting initiation factor. Cardiorenal risk reduction in high-risk patients with type 2 diabetes is the ultimate goal, and also a lot of focus on diabetes self-management education. I think as a nation, we are a long way to go in that direction. US has actually, as far as the documentation is concerned, has taken a big leap forward in that regard. Any comments, observations on this? The choice of therapies, metformin versus non-metformin agents. Let me put that way.
Basically, all the guidelines say metformin should be the first line of therapy. Why? Because it has got the longest, maybe 7 decades of experience one.
Yes.
Safety, efficacy. But still, we don't have any CVOT trials at all. But
Right.
they say not necessary because of clinical experience, everything. Oh, keep that apart. The next thing is, if you look at guidelines, what does the guidelines say? Lifestyle modification plus metformin, the first one. Whereas when we started 5 decades back, what did they practice? You said lifestyle modification 3 months, 6 months, not controlled, then only metformin. Now, why did they put metformin when it is 6.5, 6.6 along with lifestyle modification? Even today, a lot of patients say, doctor, give me 3 months. I will control my diabetes. Come back to what's your goal? 7, 6.5. If in 3 months, 6 months, somebody with 7, because even intense lifestyle modification can achieve A1C 1 to 1.5, even 2 also. If so, is it mandatory everybody should be on metformin? This is a big question always. Now, coming back to the next slide, everyone agrees metformin is the first line, except European Society of Cardiology, which said in a patient with atherosclerotic vascular risk, that SGLT2 inhibitors or GLP-1 can be put ahead of metformin. No other guidelines in the world says that, right? And that is because there was no endocrinologist, diabetologist in that group. Cardiologists have no idea about management of diabetes. That's how I put it. No guideline says that. So these are some of the things where you say. Yesterday, I think all of us have seen the great trial. What did it say? After metformin, GLP-1 unlock, then glimepiride, then you have got gliptins, okay? And these are the drugs and basal insulin.
Yeah.
Tell me in India, after metformin average 2 grams, if I tell GLP-1 unlock, not even 0.001% of my patient agree, whether injectable or oral. Then if I say, okay, 2 grams of metformin, then 90% of my patients should be on glargine. Do they agree? No, definitely not. So, and you say that the durability of glimepiride is least compared to all other drugs. You have seen the data yesterday. Now, do you know metformin? Do you think metformin has 100% durability? Definitely not. When they did studies 10 years back, in fact, pioglitazone, rosiglitazone had the highest durability compared to anything. In the great trial, glitazones were not involved because they thought it is bad, black box warning. SGLT2 inhibitors had not come at all.
Yeah.
So, if you look at these things, these are the things that even metformin, there is 11% failure every year. You may be giving metformin 5 years, 10 years. Let us say you withdraw metformin, continue others. HbA1c may be still good, but we don't know. We don't do that. Continue till EGFR comes to less than 30. That's what the guideline says also. So that is why I think metformin agree because of experience. Every guideline. Second line is your choice more than your patient choice. And you cannot put, there are 8 or 9 options, second choice, whether basal insulin, GLP-1, SGLT2, gliptin, sulfonylurea. And in India, if you ask me, probably the most potent drug is sulfonylurea.
Yes.
Let us say a patient comes with initially A1C of 11. What does guideline say? Anything more than 10, you should start insulin. Patient says, Doctor Saab, मैं मर जाऊंगी लेकिन इंसुलिन नहीं लेंगी. What will you do? Start metformin, sulfonylurea. Ask them to come back after 3 months. Patient with 11, when they come back after 3 months, 7.2. And no hypoglycemia. There are many things. So that way, if you look at it, there's a huge gap between what is ideal and what is bad.
Yes.
So it is your choice, patient choice, explain the cost, side effect, and say, in my opinion, GLP-1 is best. No, doctor, what is the cost of it? Sorry, next tell me the other one. Basal insulin, sorry, I don't want to take it. Tell me the next one. SGLT2, gliptin, sulfonylurea. I will take sulfonylurea because it costs 1 rupee or 2 rupees, whether 1 mg, 2 mg, 3 mg, 4 mg of glimepiride, cost saved. So I think discuss with the patient, second choice, advantage, disadvantage. Let the patient be informed and involved in making a decision.
Very right, sir. I mean, very comprehensive, and this comes through your rich decades of experience. Actually, it's a clear thought of wisdom for us. That's the reason we have to take these documents with a pinch of salt. Very rightly said, sir. Comments from the other panelists, Dr. Purushottam sir, Dr. Ramya Joshi, Dr. Madhura Rai sir.
Yeah,
Hello?
if I may come in or
Yeah.
I think what is important is that we have an equipoise in decision making, meaning we should at least give the patient these options that okay, this is what we have, and at least in my practice there are some overweight and obese, or maybe I would call them weight sensitive patients, who do opt for taking GLP-1 receptor agonists as their second line treatment, or sometimes even a diagnosis of diabetes after discussion that, okay, these are the 3 options or 4 options or 5 options, weight. So weight is one driving factor which has made quite a few of my patients, I would not say a big number, it is definitely not in single digits and definitely not in 3 digits, it's somewhere in 2 digits, but accept GLP-1 receptor agonists as their second or maybe first line of treatment. That's my perspective. I would say, I mean, it's not that patients won't accept, because we at times in counseling ourselves also become a little defensive in prescribing GLP-1 RA, because patient may have both price as well as side effect perspective. The second perspective is, at times we have to accept that 5% are not going to respond to metformin, and that's genetic. We have more and more understood that now, and maybe for those patients it's time to move on from metformin, and we have multiple options. I mean, at one point of time we had only SU and metformin, but now we have multiple options. And yes, once a hypoglycemia, always a problem. At least I prefer not to encourage patients to take sulfonylurea unless I use minimum 3 other OADs, and I mean thiazolidinediones. I personally don't. It's a personal matter of preference, but I prefer not to prescribe.
Very well, sir.
Can I?
Yes, sir.
Yes.
Yes, of course, sir.
We have got two aspects in when we talk in terms of pharmacotherapy. Now, one is that we are going in hypertension way. We don't talk of which to start.
Hmm.
You know, if you get a patient whose glycosylated hemoglobin is hovering around between 6.5 to 7.5, maybe you will be able to make a decision key which one to start with. If your patient is way ahead on your target, what are you supposed to do? You are going to start double therapy or quadruple therapy. Now, there is a column in most of the guidelines which say that for those which are unaffordable or the cost is the issue, where sulfonylurea has been brought up early on. So the question is, thanks to our pharma industry, if India is providing the cheapest DPP-4 inhibition, India is providing the cheapest SGLT2 inhibition, India is providing the cheapest pioglitazone along with metformin, why not start a combination which will never cause hypoglycemia upfront based on the glycosylated hemoglobin profile and the patient profile, and go ahead? This is one aspect. Second aspect is, what do you gain more out of the drug beyond hyperglycemia? Now you're talking of CVOT. So we have got a couple of molecules which definitely offer CVOT benefit. Second is, which molecule is offering one of the component of diabetes which has never been addressed beyond an ACE inhibition is nephropathy.
Mm-hmm.
No drug as on today has got such a hard marker. Basically, with most of the drugs, we have got prevention of micro or macroalbuminuria.
Yes.
Here we got real data where there is an actual decline in GFR has been restricted and sometimes reverted. Why not give the benefit to the patient? With metformin, when we talk of metformin, we say glycemic control is one aspect. What are the pleiotropic benefits of metformin? How can you forget that? Now, if you look at the real world studies and the data collated from the metformin users, not only that, people on metformin have got lesser cancers, people on metformin have got lesser osteoporosis. Are we only concerned with CVOTs? So can we, unless there is a contraindication or intolerance, can we deny our patient of such a cheap molecule which is freely available? So I will always prefer to give metformin to my patient unless it is contraindicated. I would prefer a combination therapy with a molecule which doesn't cause hypoglycemia. Yes. So we have to pragmatize our own practice based on the cost of the molecules which are available to us. And of course, other pleiotropic benefit. We have prescribing statins for pleiotropic benefit, not only for cholesterol lowering, for so many other things. Now we have got molecules which are beyond glucose control offering pleiotropic benefit. So let us look at those molecules which are cost effective and giving best possible. And we have to evolve our own strategy to use those benefits to the benefit our patient.
Very well, sir. Sir, let also I'll ask one question here to the panelists. Will this be a trigger, a thought process that tomorrow would we be, inclined to initiate combination of SGLT2 or metformin rather than metformin as a first line agent, or maybe SGLT2 that we. Yes, Dr. Purushottam, sir. Yes, sir. Your comment, sir.
I just like to make one additional comment. My co-speakers have explained everything very well, but I would like to highlight one important issue as far as metformin is concerned. I'm a big fan of metformin. I don't know why metformin is not being considered as important agent, and they are not put into this guideline protocol. The reason I don't know. What are the major contraindication of not using metformin? So my way of supporting metformin as a very important agent, unless there is a compelling contraindication to use it. If we focus on to the pathophysiology of type 2 diabetes, I think everyone will agree with me that insulin resistance is a very important issue. And probably, I think it's a more damaging than hyperglycemia, unless there is an acute complication. So I don't know. We as an Indian probably have higher insulin resistance. So metformin may be more helpful to us. And while treating a diabetic patient, if you ignore insulin resistance, and the metformin and the glucagon pioglitazone is available, and comparing the two molecules, metformin is far safer, and we have got much bigger experience, and it is also quite cheap. And despite not having a cardiovascular outcome, doesn't mean that metformin is unsafe, because we don't need to do a CV outcome trial of metformin, because the available data, the meta-analysis, the real life data. I think it is my opinion, and also opinion of some important researchers and those who are treating diabetes for so many decades, that metformin is a safe agent as far as this cardiovascular disease atherosclerosis is concerned. And what I believe, and my knowledge of pathology also, and the physiology of type 2 diabetes is very important, that we have to address insulin resistance from the very beginning. And there are plenty of reports to show that even in pre-diabetes, or rather before that, when the person is developing insulin resistance or already having some degree of diabetes complications, pre-diabetic patients are having diabetes complications, which is because not of hyperglycemia, because of insulin resistance and related problems. So I have a drug that metformin, which main action on insulin resistance, is cheap, safe. I don't know why we are not going to use. Definitely, we have to individualize that. That as person with 8% or 8.5% of HbA1c is not going to have blood glucose HbA1c level 6.5% with metformin alone. But I don't know, in this crowded place, you are just omitting metformin in the armamentarium of type 2 diabetes medications is beyond my imagination, or rather logical conclusion. I don't know why. Metformin should be the first one, unless there is a compelling contraindication, and you can use whatever you are telling us, combination of 2 or 3 drugs, including metformin. I think metformin should be the drug in any combination, unless there is a contraindication. And the pathology of type 2 diabetes is quite clear that it's a very important drug.
Very well, sir. I think we cannot ignore metformin, whatever the glory of evidence is, what we may come across. At least that's an established molecule for substantial period of time. So something which we already know of, as far as the choice of glucose lowering medication in people with cardiovascular disease, the data is, at least I would say, the evidence-based medicine tells us that SGLT2, GLP-1 would be an important element in that regard. So as far as the recommendations are concerned, in people with established CVD, a GLP-1 agonist with proven benefit should be used to reduce MACE, or an SGLT2 with proven benefit should be used to reduce MACE and heart failure and improve kidney outcomes. That's I would say, a new domain which has emerged in last 2-3 years in people without established cardiovascular disease, but with multiple risk factors, age 55 and above, obesity, hypertension, smoking, dyslipidemia, or albuminuria. GLP-1 agonists with proven benefit could be used to reduce MACE, or an SGLT2 with proven benefit could be used to reduce MACE and heart failure and improve renal outcomes. Heart failure in people with heart failure, CKD, established CVD, or multiple risk factors for CVD, decision to use GLP-1 agonist or an SGLT2 with proven benefit should be independent of the background use of metformin. This may be a tall statement, ahead of time, getting overboard. We will discuss that out, but I think that's an important element in this document. Multiple risk factors for CVD, addressing those risk factors itself becomes a differentiating perspective. Comment from the panelist. What is your viewpoint regarding GLP-1 agonist? Can it be equated with SGLT2, considering the practicality of the usage, the cost factor, first of all? If I put that into the perspective of diabetes, RSSGI wheel, the cost factor plus the journey of evidences. Comments, observations. Can SGLT2 and GLP-1 agonist realistically be equated on the similar line?
See, when RSSDI guidelines was made, the SGLT2 inhibitors were different. They were not generic. Today they are generic. So that way you cannot compare today SGLT2. Many of the SGLT2 are as expensive as some sulfonylureas, if not the other. So cost is not a factor in that sense. But if you look at CKD, that SGLT2 inhibitors score over GLP-1 analog. GLP-1 analog are better in a cardiovascular risk case. And same thing, the guidelines also says, if there is cardiovascular, the first thing is GLP-1 analog, then is SGLT2. If it is CKD, SGLT2 inhibitors first, GLP. Whatever it is, and like the previous speaker was telling, it is not contraindication to metformin. It is intolerance to metformin, because 10 to 15% of the patients cannot tolerate metformin. First of all, some people cannot tolerate 500 mg. Every day I see somebody coming from 500 to 1000, one nausea, vomiting. 1000 to 2000 they have got. So most often the contraindication is only when the creatinine EGFR is less than 30. Most often at the beginning, it is not contraindication, tolerability, 15-20% does not. Of course, cost is always there and you can take it. I think Dr. Chatterjee has something to say. Yes, sir.
Very well, very well.
Sir, regarding the intolerance, most of the time what we see in our clinical practice, it can be reversed in a better way by counseling and change of preparation. Because in our country, we have multiple preparation of sustained release preparation, immediate release there, and they behave differently. So if you we must have experienced it that all metformins are not same in our country. This is a very important factor as far as this metformin intolerance is concerned. This is my observation. I would like to know your comments, sir.
I agree with you. Those of us who have seen 5 decades back, when immediate release metformin was there, at least 95% tolerated. And as Dr. Chatterjee said, the moment you change to the slow release, this intolerance increased. This is also my seniors who have lived 50 years and practiced SC, I agree. Second thing is never start metformin 1000 milligram twice. They will have incompetence. Start with 500 once a day. After 10 days, 500 twice a day. Then 1500, then 2000. Everybody cannot reach 2 grams, though that is the maximum. So you have to start slowly metformin. Unlike others, SGLT2 single dose, gliptin single dose, GLP-1 analog, at least dulaglutide and other single dose. Only Sema and Lira have got a increased dose. So that is why I think, as you said rightly, there is a difference. If you look at West, most of them are immediate release. India, they feel convenient once a day they brought. Otherwise, even now in the West, all our clinical trials Till recently, we did with immediate release. They say we don't use the long acting at all. So, yes, I agree with Dr. Chatterjee that it may make a difference. Thank you.
Yeah.
So
Very
the
well said.
problem of intolerance could be with any drug. And it has been very clearly mentioned, and Dr. Prasanna Kumar and Dr. Chatterjee has very aptly brought out that GI intolerance can be obviated in a substantial number of patients if you are using it judiciously and with the proper dose and a proper formulation. And that's why I said for me, metformin contraindication is intolerance / a definite contraindication. These are the only two things. And otherwise, and if you're talking of, can't a patient develop intolerance to sulfonylurea? Can't he develop intolerance? Because any chemical moiety is likely to produce intolerance. And sometimes the patients are very particular. So you have to take the patient account into cognizance. You cannot simply tell that. Even B complex sometimes produce so that's the thing you have to take into consideration. So of course, for metformin, just like a GLP receptor agonist, oral, they have got a dosimetry. Here also you have got a dosimetry, which you have to follow. Since it is an expensive molecule, you take length of time in explaining the patient that this time I will give you 0.6, then 1.2, then 1.8. And here you start with the full blown, and then the drug comes into disrepute. So I always think that metformin is a background drug, given the cost, given the pleiotropic benefit, and given this efficacy. On the top of it, whatever you add, and now we are not in an era of monotherapy. We are in an era of polytherapy. And an Indian pharmacy is providing us excellent combination.
Yeah.
Where the compliance becomes so good.
Yes.
And one drug which is very conveniently pushed aside by most of the companies is pioglitazone. And you believe you me, for the patient where I prescribe pioglitazone, whether it is DPP-4 or SGLT2 or it is sulfonylurea, all these drugs become very durable if they are given in combination with a low dose pioglitazone. So our industry has very well found it, and we have got combination of, and I can tell you the patient who are taking metformin, sulfonylurea and pioglitazone combination, this combination is going to last for years together.
Yeah.
So that one has to look into it. So all these things, our experiences, unfortunately, we are not able to collate our experience. We are not able to put it into a larger perspective of so-called clinical trials. But our individual experiences are enormous. And we have been using drugs, and we should not talk of now over and above, if I have to prescribe, nowadays cardiovascular stroke, not stroke, but CAD prevention is much in the surgical domain. Hydrostatin and early PCI they are doing. But there is nothing to offer for kidney disease. And it's a wonderful diuretic which causes natriuresis is SGLT2.
Yes.
I think after some time, SGLT2 will be taken as a diuretic, proximal loop diuretic, rather than as an anti-diabetic drug.
Yes.
And it is causing such a severe natriuresis. And it is changing the whole renin-angiotensin system, suppressing the renin. So this profile is going to come up, and probably this is responsible for most of the benefits we are getting. So I think हम लोग जितने नमक खाते हैं and salt eaters, we are loading ourselves with sodium. Probably Indians are going to gain a lot more on this SGLT2. That's my perspective.
Very well. In fact, we'll take this question also. This is from Dr. Ashwini Kumar sir from Kanpur. Combination of SGLT2 with DPP4 would have better therapeutic effect than adding metformin to either class of the drug. I think tough one to address.
No, we have addressed it. Like, we are not talking of 1, 2 or 3. Depends upon your target. Where there is adding this or adding that? Ultimately, we have to come down to a combination.
Yeah.
So it's like when you add.
Yes. And I think that all puts into the thing into perspective of personalized approach, what we are talking today.
Definitely.
Yes. So a quick glimpse on in people with heart failure, we already know of SGLT2 with proven heart failure benefits in the population. Dapagliflozin, empagliflozin have shown the way that how the DAPA-HF Emperor preserved trials across the spectrum. It has shown the benefit. We are not getting into details for the sake of time. Renal implications, even in patients with heart failure, emerging perspectives are very much clear on that recent data, which has shown that. And in people with CKD, that's again a recent domain which is emerging so rapidly as far as evidence is concerned. SGLT2 with primary evidence of reducing CKD progression, changing the curves, changing the deterioration of the renal impairment. That has been one of the fascinating journey for these molecules. CKD perspectives, ample number of evidences are there in that regard. So your final comment, a quick comment on from the panelists as far as the utilization of the contemporary agents. Fundamentally, do these guidelines impress us for our own Indian situations, or is it ahead of time? Is it redundant, or we need our own thought processes to be documented, have our own perspectives and viewpoints? But certainly one thing is clear from this: metformin may not be the standardized approach as it has been. I may call it as before the guidelines era, as yesteryears and the future, at least from this documented consensus report. Your perspectives on, your crisp thoughts on these guidelines. Does it appeal us, or is it getting overboard, considering GLP-1 analogs being at the higher level?
I think as far as SGLT2 recommendations, it is purely based on level A evidence, as you can see, and we have data and every sentence that is made. I will take it as it is. And also it is a now generic drug. I'll be very happy to use, because 65% of our patients are obese, and nothing other than SGLT2, GLP will reduce weight. Metformin and all others are neutral. I agree with the conclusion and recommendation 100%.
Very well, sir. Thank you, sir. Comment from, yes, sir, Dr. Purushottam, sir.
Regarding SGLT2, definitely, as I said, I fully agree with that. And I'm very happy that the SGLT2, apart from the cardiovascular benefit, it is only one drug after probably 15 or 20 years that can actually benefit our patients with kidney disease. So I think it's a most welcome sign, and the SGLT2 inhibitors beyond glycemic control and this cardiovascular outcome, the renal outcome is a very, very important evidence data. And I am very happy that now I have a drug that can actually prevent or slow down diabetic kidney disease, or rather, now we can call it beyond diabetes and other non-diabetic kidney disease also. There are recommendations from Nephrology Society all over the world. They are recommending use in glomerulonephritis and other kidney disease. So I'm very happy that we have this drug to prevent kidney disease or slow down kidney disease.
Very well, very well.
So it's not only like when you're talking of these trials from the very beginning, as these drugs started coming, initially as a secondary outcome, you had always a fight between whether it offers this at cardiovascular protection or not. But heart failure and kidney protection was documented across the board, whether it was looked as a secondary outcome or as a primary outcome.
Yes, sir.
So we have got a molecule which no doubt has a
15, I remember, documented. It was well documented in that regard.
So we have got an heart failure. It's a wonderful molecule.
Yes.
So how can we ignore this?
Yeah.
So if one molecule has got one attribute of CVOT prevention, another molecule has got everything: CVOT plus kidney plus heart failure. Which one will you pick, Dr. Wadhwa? Unless you are talking of pharmacoeconomics.
Yes.
And then pharmacoeconomics rules the world.
Yes.
So once that come into perspective, the guidelines also they twist. and
Yes.
turn.
And now it's getting into the prevention element also, not just the,
Absolutely.
the overt intervention. I think it's getting overboard even beyond the utilization of what statins could do in dyslipidemia.
Yeah.
That has been the impact.
If I have to add something, I always try to look at a statement to
Mhm.
see what the statement has exactly added to what I am already doing or what I know or what the
Mhm.
previously known statements have done.
Mhm.
And maybe, I mean, we all knew this SGLT2 inhibitors. I mean, the evidence level may have gone up, but in practice, it is already there. The only thing which I felt was that in an initial stage, they have advocated use of a combination therapy and approach that's quite welcome.
Mm.
I mean, that's something new. But we need to remember that it has came from Europe, and Europe has
Yeah.
already taken steps in this direction. Uh,
Dr.
I
Amay,
mean, yeah.
if I'll just take you back to American
Mhm.
College of Clinical Endocrinologists guideline, which
Mhm.
has more than 10 years back
Mm.
said a combination should be used, and
Yes,
they have
sir.
given guideline. Yeah.
Completely agreed.
So solid endocrinologists, they always give combination.
Yeah, that's true, sir. Completely agreed. And
So
ASE has always been in the favor, but
yes,
ADA has
ADA is like
yes.
something is it's not scientific that much as compared to ACE
See,
and
I mean, somewhere they should have practicing clinicians making guidelines. That's true. So I think that I mean, what we got an undercurrent before has been strengthened in these guidelines, is what I would say, and maybe this is a welcome change.
Very well. I think we are as a country, as a nation, we are an experience-rich nation, with the lacuna with respect to the evidences. We are not supposed to have the plethora of evidences because of we cannot compare apple and oranges. We can just imbibe, reflect some scientific evidences to a larger picture, of course. But certainly, yes, I think as far as our experience goes, combinations has been at the forefront, not only diabetes, look into any spectrum to that overboard across therapies. The regulatory authorities had to curtail that. It had been gone over to board to the extent of the spectrum of irrationality. But nonetheless, measures have been taken, addressed. But I think at least in diabetes spectrum, the question of irrationality did not never exist. But we have been the first movers in terms of providing not just to our Indian patient, to the globe as well, rest of the world as well, to have the benefits of combination therapy. We have already seen the bombardment of the SGLT2 and DPP4, overnight, literally the floodgates open. Nothing nothing wrong in it. At least the accessibility is there across the country. Somewhere some brand is available for the relevant patient, irrespective of the geography of the diverse country of us. I think that has evolved rapidly. Let me shift gears. Let us move beyond the guidelines. Some hypothesis generating research papers. These have been tough papers. Some are very, very intriguing. Moving beyond the pharmacotherapeutic approaches, quick glimpses, and we'll have quick comments and run faster to close the meeting in a couple of minutes from now. So diet and all-cause mortality in patients with type 2 diabetes. I think these all studies, at least these are all systematic review meta-analysis. But yes, I would say in-depth analytical perspectives, identifying an appropriate topic in that direction, identifying the gradient and the quality of the consumption of the type of food. So this was the actual recommendation. One of the bases was that limited intake of saturated and trans fatty acids, higher intakes of Bufa Mediterranean or DASH approaches to stop it. There has been a couple of good recommendations, but overall, the gap has been, these are all population-based evaluation. So that the parameters had to be ironed out, and this has been an attempt in this particular work, which reflects that from a micronutrient and secondary compound. So it reflects that higher consumption of perhaps whole grain, fiber, fish, omega-3 fatty acid, vegetable and plant protein may be associated with the relative reduced risk of all-cause mortality among individuals with type 2 diabetes. Higher consumption of eggs and cholesterol were positively associated with all-cause mortality among individuals with type 2 diabetes. So aspects of healthy diet are associated with all-cause mortality in person with type 2 diabetes. But definitely, yes, the trigger for the thought is more evidence is required to strengthen that evidence. So gradient as far as the relative risk for mortality is concerned, can we say these are like some food elements may be protective from mortality, or some may be inducing mortality? Your thoughts on, quick thoughts on this? Maybe a bit controversial.
Basically, all these are meta-analysis. You
Yes,
cannot
sir.
have randomized control trial.
Yes, sir.
Second thing is food is very complex. You are
Yes, sir.
talking of certain protective factors. You don't know the other factors which are putting you at risk. In 70 years of my life, what all good things I have eaten, what all bad things I have done. Can you dissect each one and say, my longevity is because of this. If I get a heart attack tomorrow, it is because of that. Even after 100 years, people don't agree tobacco is the cause of heart attack many times. It's the cause of cancer, still controversial. So these are the things that way. General guidelines are good, have more fruits, vegetable, omega-3, right? But, and these are recommendations. Okay, you take fruit, vegetable. To that extent, yes. And we should also encourage people to do this based on the general assumption. All said and done. You can talk hours together today about diet, and your dinner tonight, Saturday or Monday, may not be the ideal recognized to anybody.
Yes. And perhaps these are all very tough studies as far as, we cannot eliminate the confounding variables in such diverse studies as well. So let us move ahead to the other perspective as well. This was another paper, association between type 2 diabetes and dementia. UK Biobank has been a very powerful group evaluating various other perspectives also, but dementia gradient impact, 30% of dementia risk is caused by modifiable risk factors. Association between lifestyle and type 2 diabetes and dementia, the triangle of that was being evaluated in this. So perhaps with type 2 diabetes versus without type 2 diabetes, risk of dementia again is variant in that regard. Adult with type 2 diabetes have a lower risk for dementia if they live in a healthy lifestyle versus living an unhealthy lifestyle. Adjunctive benefits of a positive lifestyle, which can be fine-tuned, modulated, and looking into that direction. Any comments, observations on this? Additional benefit of better lifestyle on the risk of dementia.
The other day, I was looking at the report of a UK Biobank on consumption of salt. And it recommends that those people who are taking less than 5 grams of salt. How many of us can restrict ourselves to less than 5 grams? So these are very difficult areas. Now, what we are forgetting in our country is such a populous country with such a bad town planning. When we were kids, we used to play. Dr. Prasanna might have played much more than us. There were parks, there were roads, there were no vehicles, and you were cycling. Now, how many of your children are able to exercise freely without the fear of an accident? You don't have a pavement. You don't have a city planning. Why don't we take all these into consideration? Your exercise, stress factor. So if we try to dissect all those things, and moreover, as we are proceeding, my grandfather died at the age of 100, and he has in his life he has made a point never to take dalda. He used to always eat in Shuddha ghee. And aaj bhi, when we take anything made of Shuddha ghee, it never gives you heartburn. It doesn't go rancid. So these are the things. You have so much of diverse eating habits, and you cannot compare. So it's anybody's conjecture. Of course, it is a scientist's delight. They try to do meta-analysis and try to come out with something. Do it. So it's fine.
Dr. Madhukar, as you said, let us say you tell me, sir, you eat instead of 15 grams, 5 grams salt, you will live 5 years more. Doesn't matter. Let me have 15 grams, 5 years, right? Rather than isn't it? And
That's what I'm saying.
we have reached a stage where diet, I don't think at this age we should eat. Whatever you have done all these years is good enough, right? For a younger person, obese, yes. I don't think you can change. You can't make a South Indian eat North Indian food, North Indian,
Yeah.
South Indian food. And even after so many years, we cannot change our diet habits. I agree with you.
Very practical thoughts, sir. Yes. So let me move ahead. Consumption of different animal-based foods. This again is a dilemma. The definition of it, umbrella review of meta-analysis or the prospective studies, at least a strength higher. The gradients are a bit different. Adults who consume more dairy, milk, and yogurt have a lower risk for developing type 2 diabetes. We are not consuming milk the way we used to, when we were children, or at least the earlier generation. Eating more yogurt, low-fat dairy may reduce the risk of diabetes in that regard. So they have taken into account 13 meta-analysis. 1 glass of milk per day was associated with 10% lower risk of diabetes. 200 grams of dairy in a day contributed to 5% dip in the odds. 1 bowl of yogurt a day was associated with 6% drop in the risk of diabetes. Attributed to vitamins, nutrients, the cause-effect relationship, at least the postulations, bioactive compound in milk that have a positive early impact on the glucose metabolism. Nitrates, nitrites, sodium in red meat could be detrimental and also damage insulin-producing cells of the pancreas. Saturated fats, as sir you were mentioning, inflammatory effects. Rancid lead properties of the food can reduce insulin sensitivity of the cells. Low-fat types, milk, yogurt could be appropriate for optimization of type 2 diabetes prevention, a step going ahead in that red. Moderate amount of fish and eggs could represent a suitable substitute for red and processed meats in most eating occasions, and perhaps eating dairy products can mitigate diabetes risk. And let me tell you, I don't have any conflict of interest with Amul at all. So any comments, observations on this? Practical experiences as well. Are we consuming?
I don't think so. And the problem is, looking at the TV reports day in and day out, if it is a dairy product, what exactly we are consuming, we don't know.
Yes, that is.
Have we ever taken into consideration of the adulteration which is going on? Of the hormone injections which the chickens and this dairy animals are taking? What is going to be the impact of this endocrine busters?
Yeah.
So there are so many issues and are we getting the milk the way we should be getting? Are we getting yogurt the way, because yogurt is supposed to be a beautiful probiotic.
Yeah.
Rather a prebiotic and along with probiotic. So all these things, if we are taking in a proper perspective, it is good.
Yes.
But whether it is available, if it is available, what is the quality which is available?
Yes.
And what is the source from which it is coming?
Yes.
So,
and are we taking endocrine disruptors or compounds that should mitigate the diabetes risk? That's a gap.
That's all these things need to be worked up.
Absolutely, sir. Very practical, relevant. Sir, Dr. Purushottam, sir.
Now the problem is that I think all of us from different corners of India, 100 ml of milk or 100 gram of whatever dairy product means different, absolutely different, and it varies from every society. So I don't think we are anything near to quantify and qualify this amount of these things. And it is a huge job to make it a standard for in a country like ours or all over the world. So there is a lot of gaps in this knowledge. Number one, and number two, what Dr. Raya and you also mentioned that we are taking a lot of disruptors, and there is a proven data. Plastic bottles. Now there are chemicals like that which actually causing serious damage to our endocrine and neurological system. I don't think nobody is going to talk about that in in small studies, but again, this is something a different ball game, and for that we need a lot of rules, regulations to be properly utilized and also placed.
Yes, agreed, sir. So let me move ahead. The quality of weight management program supervised, yes. And what are the implications? So early weight loss is the sole predictor of weight loss reduction at 3 years. And the early legacy effect may be applicable in the gradient and the quality of weight loss which has been initiated. This has been a study from UK in that regard. So earlier modulation of the weight loss becomes important. Earlier weight loss is a behavioral weight management programs predicts long-term success. So each 1% of body weight lost in the first month of participating individuals in a behavioral weight management program increases the odds for short-term and the long-term weight loss. So basically postulating the predictive model that how well it is being done in the initial stage would be a reflection from the long-term implications. Any quick thought on this? Does it make sense?
See, what I made from it is that if you lose weight early, probably you are going to be able to, have a better outcome, better weight loss, or better weight. Of all the abstracts, and I was quietly listening to them, one thing we must know that they come from separate setups, separate areas, as well as separate geographies, and maybe separate mindsets, the way they have done. I was trying to look at what could be implementable in my practice and what I can look at.
Yes.
I think to an extent, weight has, or maybe weight management has been a challenge despite whatever medications and whatever armamentarium that we have, and achieving sustainable weight loss has been a great challenge. What probably I can make of this is that what this particular setup was giving as an intervention, or maybe what this particular geography was using as an intervention, those whose genetic makeup gave weight loss with that, they managed to do better. You see a lot of people using a lot of techniques. It's not that one size fits all, and maybe I have learned it a very hard way, that if whatever you have preached has not worked, it's time to relook at patient. You may not have his entire, in 10 years down the line, you may have a whole genome map which will say that prescribe this particular thing, but then you have to just change. Time restricted eating not working, go on carb restricted eating. Time restricted eating not working, go on this particular pattern or X particular pattern, and then have maybe mix match and deliver. That's what I would say means for weight clinic practitioner.
Yes. This was another one, perhaps a difficult one to be done, something not easy thing to be looked, but at least from the Western world, I think this was a different perspective, skin reactions to technology devices. So it looks that it's a relatively common problem with 25% of users experiencing skin reactions when using insulin pumps or CGMs or flash glucose monitors. Most people use avoidance strategies to lessen the effect, and there is a very low rate of device test discontinuation. So high proportion of people experiencing reactions and just working around the best they can. So this has been an interesting study termed as QTA study, which looked very closely, evaluated the varied patients across the spectrum, CGM, pumps, with a good gradient and the definition of the skin reactions in terms of description, prevalence, determinants, and rate of permanent discontinuation. Cause-effect relationship perhaps substantially well established, and the avoidance strategies also look very carefully in that. So, so does it make sense, or it's too early or difficult to comment our own experiences or unexplored area?
I don't think so, because I have been using almost 10 years. Today I had a patient who has been on CGM for 2 years. Every month she is using 2. So with the old one, what is the cost of it? It is almost, let us say, 24 per year, right? 24 per year will be 50,000. 2 years, 1 lakh she has spent. With the latest CGM, probably are going to spend double, almost, let us say you spend 1.2 lakhs per year for monitoring. Is it necessary? I don't agree that 25% I have been using hundreds and thousands of patients. Less than 1% of them have skin reaction. Even to that is mild, it's not bad. I don't agree that 25% will have
Yeah.
CGM. It is, I think, exaggeration of it.
Yeah.
But we have to use it very discretion. Maybe type 1 diabetics, maybe once in 3 months, depending what they can. And provided the data is used to fine tune the dose of it. And some patient with type 2 also need. But trying to say every patient on type 2, oral anti-diabetic, on lifestyle modification, it is taking too far from that. With discretion and where it is absolutely essential, we can still use it because we are moving away from urine sugar, blood sugar, HbA1c to time in range. And this is good, though it's an algorithm, not a perfect one. Later on, probably we will have something which will have much more accuracy and maybe non-invasive also. This is minimally invasive. You may have absolutely non-invasive. At that time, I think it will be useful.
Absolutely. So in fact, that's the reason it caught my eyes. If I compare and contrast, this is an irony and paradox. On one side, as a nation, we live in a humid environment, a lot of sweating, credit to the humidity. That's the reason patches overall, therapeutic patches, with the fentanyl patch and so many other drugs, industry also has exploded. But as a country, we never succeeded in patches as compared to the Western world where they have, adopted or accepted patches relatively better off. And this actually caught my eye, such a high grade of unacceptability. This would actually entail or caution the regulatory authorities for withdrawal of some of the devices then, if that has been the rate.
Right, I don't agree.
But I would say, this is just a, food for thought and an eye to watch in the subsequent, patients may not be reporting, that may be the case or a hidden agenda, somewhere less than 25% for sure, but maybe more than what we currently observe, a better eye to watch.
No, if somebody has reaction, nobody will keep it for 14 days. Do you think eating rashes, somebody will keep quiet 14 days? No. When I ask them after 14 days, most of them say, I'm happy. If they have problem third day, they will throw it off. I don't agree that they keep it 14 days in spite of all severe reactions. Highly unlikely. Maybe a bias paper.
I agree with Dr. Prasanna Kumar, sir. Whatever my patients are using CGM, first of all, they are spending on it and they are also spending on the pump. Any minorest of the reaction, they will come back and immediately report to us, make it a point that, and I have not seen more than 1 or 2 patients in a year coming with this.
Yes. So let's abandon that paper, perhaps.
And in our country, there are places, Jodhpur, Jabalpur, whatever it is, 40 degrees. And they have used at 45 degrees. See, to say that it does not work in India is not correct because they have checked at all temperature, -10 also 40 degrees, before this technology has been accepted. It's not only meant for Europe. In fact, we started using 5 years before FDA approved. I spoke in ADA, my experience of AGP almost 10 years back.
I remember that was your, perhaps you were the only Indian to deliver that. I saw that 2016, I think. That
5
was
6 years back.
Yeah, I remember that. Yes, sir. Yes, sir. Dr. Purushottam, sir.
I think it's not a comparison, but I think there is a paper by Professor Kumar. It has shown that like SGLT2 inhibitors and genital tract infection, we have less incidence of genital tract infection compared to the Western country as far as SGLT2 inhibitors are concerned. It varies from population to population, and definitely we have to take it a consideration about the study population and
yes. Very well. So let me put a different thought here. There was a separate session on diabetes and climate change, implications for global health as far as the diabetes care is concerned. So that actually has implications as far as the healthcare, which has a direct role as far as the climate change is concerned. That mentioned some of the examples as well as supply chain, the benefits of using digital tool, designing lower impact clinical trials, reusable equipment, recycling, and newer materials. And it's an ongoing program of work across all aspects of healthcare. One interesting comment which came up, in the virtual consultation, it may sound that virtual consultations are actually may lead to better positive impact on the climate change. Patient doesn't have to travel, doesn't have to, come to us, saving a lot of carbon emission, etc. But there was a good discussion. They said that virtual clinics actually are leading to worse climate environment detrimental effect, because one side, patient if comes directly to the clinician, all the investigations are done at one stop. Otherwise patient has to repeatedly travel to a lab to get the test done, again travel back and forth are much more because of the virtual consultation. That it looked appealing. So they actually talked about the entire process, how the consultation process, at least from the, these are all new thoughts, I would say. We are, it will take some time to approach, and it can be addressed by the comprehensive setup like NHS. They are working very strongly on the processes, how the patient consultations happen, how the emissions from the setups are modulated, how the individual diabetes, for example, when the patient need to visit, when the patient need to have a consultation with the primary care clinician, when it has to be escalated. So patient awareness itself, in our country, the concept of headache means neurologist. That's the concept. So does it make, these are all the attributes which actually may add up to the, somewhere we are adding to the carbon footprint somehow, somewhere, as a small steps. So these were some of the examples which were shown. It's chronic disease for that matter. Even the quantity and the quantum of the disposable, the patient uses so many things which could have been utilized, or energy saving processes can be built up. So diabetes sustainability and waste management is definitely a complex topic. Political will is required. In fact, they also discussed that, for example, in UK, they already have it since 2018, the sugar tax. The amount of sugar in the beverages and the food will determine the quantity of the test. It's like, different gradients of GST, what we have, something like, the quantity of the sugar will determine the higher the sugar content of a food, higher would be the taxation. But now with the cost of living crisis in UK and Europe, with the inflation going, at very high, political pressure is there to remove all those taxes so that the cost of food products can come down. So they were discussing that, this is a detrimental effect for all the long years of hard work which are done towards enabling a better climate, addressing the climate change issues. It's going into one side a revenue source for the government, one side addressing the climate change. These are all complex issues, right from the food policy. In fact, a lot of discussion on the types of insulin pens, actually, whether disposable pens versus non-disposable pens, how does it mix match? We don't realize on a one-to-one basis, but they showed very nicely that how policy framework would be so important in terms of checking the entire dimension altogether. Any comments on this? Climate change and the diabetes. Is it a far-fetched idea? Should we start thinking on that domain?
That is good, but the thing is, you cannot take one view only. You have to take all the views. Whether it is, see, COVID has taught us so many things. Now, what was, I've been using e-consultation, video consult, not today, 10 years. They said, this is not possible, this is not practical. And I have managed it all these years, and even no patient asked for it. Ultimately, it is the doctor and patient choice. Somebody, even in Bangalore, from one end to other, it takes probably 2 hours to travel. And even the ADA guidelines say 2 visits per year is enough. Every 3 months, patient need not come. And you look at the cost of traveling and pollution and other things. So you can't generalize. If you look at NHS, NICE guidelines, it is only economic cost they are bothered. They are not bothered about anything else. So what applies to one country does not. Second thing is blood test. Today, what do they say? Anything you want, every morning 6 o'clock to 10 o'clock, a technician will come draw blood for maybe 1/3 of the cost. For one strip of crocin, they will come and deliver it to you. It is not like UK. These things are not available there at all. You can have tertiary care tomorrow morning. You want to see 5 specialists, affordable, available, and adaptable also. So what they calculate in UK, ESA has no meaning in India. Economics are different, logistics are different, infrastructure different, mindset is different. And with all that, patients say, doctor, don't worry. I want to see your face. I want to talk to you. Tomorrow you say, everybody I laugh for. No, 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 no. I want to see, when I see Dr. Chatterjee's face, my heart diseases are gone. This is what they tell you also. And
Yeah.
regarding sugar and all, can you believe any Bengali living without sweets? No, not at all possible. Whether it's fish or rice or rasgulla, if you want me to live 100 years, sorry, I don't want that. So all these things have to be individualized, and what the guidelines and they say is true for their country, our country, and India is not India. It is United States of India. All
Yes.
4 of us talk different languages. Only common thing is English. Every 100 kilometer, food changes, dress changes, accent changes, right? So that way, even in India, what applies to Kolkata does not apply to Bangalore at all. So
Yeah.
each one practices medicine locally rather than say this is the only best thing.
Sir, another interesting terminology which was brought in the climate change was greenwashing. What they call greenwashing is that under the disguise, to sell more products, even in the insulin pens, someone would start claiming that my insulin pen is more globally sustainable, more green, emission friendly, etc. Under the disguise and ambit of that, under the spectrum of climate change, people start, organizations, commercial organizations start claiming, getting overboard on their claims, actually disguising and enabling or thinking people to buy that if I buy this product, I am saving the environment or climate, which may not be, very true. In fact, in Italy, the restaurants have started putting on the menu that with the corresponding dish, just like in UK, there is a recommendation that the menu should also elaborate the calories. They have started putting the footprint, the global carbon footprint with each menu and dish. This is an experimentation. There are publications, a lot of changes perhaps which are happening. So last quick few slides, good reasons for adopting optimal dietary habits for a lifelong type 2 diabetes prevention. I think this is a big arena as far as the population dynamics are concerned. Plant foods versus the other dietary agents. We have already seen some of it. We'll not get into the discussion on this, but yes, reinforcement of the fact that certain elements would have some diabetes prevention aspect. So plethora of evidences as far as SGLT2, flood of data. I'm not getting into details of that. The paucity of time, few just minutes to close it quickly on that. So just a quick reflection on the new dimensions, small evidences, but hypothesis generating, intriguing parameters, the evaluation techniques which are evaluating the impact on myocardial performance, endothelial glycocalyx in patient with type 2 diabetes. So they have evaluated with DAPA, with combinations, pulse wave velocity. In some clinics, we already do it. Good, I would say, an attempt to evaluate the different markers beyond HbA1c in that regard. 4 months treatment with DAPA or dulaglutide, comparative evaluation with cardiovascular function in ischemic stroke. So varied patient profile as far as the utilization of these newer agents, SGLT2, GLP-1 analogs, so and so forth. So these are all pictorial representation, but certainly, yes, a long 4-month therapy with Dula or DAPA improves arterial stiffness or the cardiac performance despite a similar HbA1c reduction. So factors which we need to evaluate can be different, which were earlier not being explored. Endothelial function and albuminuria compared to DPP4 inhibitors, as far as 1 year treatment with Dula and DAPA is concerned, on a similar model, similar scale, but a long-term evaluation, relatively long-term, with a complex biochemical evaluation as far as cause-effect relationship implications on the endothelial dysfunction. A quick comment on this new data. This is just a reflection of so many trials, so many studies which have been presented this year. So does it appeal us? Does it give a better confidence on the existing data in a precise evaluation of these molecules? Dr. Amya Joshi, sir, how does it add value to our own confidence on these molecules?
I think I agree. That's what I said, that these are individual representations. Maybe we have to look at these as themes which will evolve over a period of time. So maybe it's time to take it step by step. Yeah, I
Right.
mean, what you presented was interesting to go through.
Yeah. Maybe small studies, but time will only tell how it evolves. But definitely a good research attempt, considering the
Yes.
fact these molecules are new, are getting off patent. In our country, it's already off patent. And these are all non-industry, but most of the studies were non-industry funded. These are studies from the academic centers of excellence, which now are exploring varied profiles on something the landmark trials have shown us already beyond a step ahead.
In fact, they want to see what is the mechanism behind that.
Yes, cause-effect relationship is getting more clearer actually.
You know, finding the mechanism is a sort of is a bonanza for basic
Yes.
scientists.
Yes.
They want to look into exactly. But one area which I am finding very interesting with dapagliflozin or as SGLT2 is one untouched area in diabetes, which is a very common problem, NASH. And
Yes.
it is coming up in a very good way. The
Yes.
data are reflecting in a very good way.
Yes.
Because this is one area where we are not able to offer our patients anything.
Yes.
And DAPA is one where the results are very robust.
Yes.
So I don't know whether they have brought it out in
Yes.
this spectrum or not.
In fact, there was a separate session on the treatment of NFLD. I was pleased to find that, and they're exploring even newer agents in that regard.
Yeah, definitely.
Yes. Yes. This area cannot be ignored. In fact, this was another interesting paper, effect of DAPA on renal and hepatic glucose kinetics in type 2. There's a lot of new insights which are emerging so rapidly, flood of data, I would say. And these are all titled papers with dapagliflozin. This was another one, something which we know of, but very well documented, interaction between early DPP4 inhibition and HbA1c variability. Using the technology and the DPP4s in tandem, that how well, something which we know that newer agents will have some postponement of insulin, some delay of insulin utilization. But what is the impact of glycemic variability, which actually has its implication on the actual usage of these molecules? So we'll just quickly, in few seconds, we'll close up. So this is the message from this, that glycemic variability and utilization of DPP4 inhibitors, there is a connect, and early utilization of DPP4 inhibitors, especially with combinations, can lead to better impact on the overall spectrum of the management of diabetic patient. Mortality benefits, SGLT2 and GLP-1 agonists in young people with peripheral arterial disease, something new dimensions, yes, which has clearly shown that combination of these agents could have better implications as far as the mortality benefits is concerned in people with peripheral artery disease, multi-comorbid scenario with newer drug. This is the last one. This is the letter by Queen Elizabeth on 11th January 2022, as we celebrate 100 years of insulin. I like the language, be it our English is not our native language, but yes, the wisdom that how insulin has come closer to achieving the vision of world where diabetes can do no harm. I think that's the era, that's a meaningful insights with respect to EASD. If I look into the broader picture, whatever the scientific evidences are coming, be it evaluation in multiple complication scenario, be it a preventive scenario, the spectrum of evaluation, I think the whole dictum and the wisdom and Sir, your final word. This is all I had to share as far as the plethora of evidences are concerned.
Thank you. It is good and a nice presentation. We have covered probably a lot of things in just 1.5 hours. Maybe even 4 hours is not sufficient. At
Yeah.
least whatever you thought that very important guidelines, we have got it. And only discussion among ourselves like this probably will become wiser, because 360 degrees feedback, north, east, southwest is useful. So thank you very much. I don't know whether it's because some of them are busy. I also have a meeting shortly.
Yeah.
So thank you very much and take care.
Thank you so much and making the meeting so memorable, and thank you, sir, so much.
Thank you.
Hello.
Yes.
Hello?
Yes, I can hear.
So can we end this meeting?
Yes.
Okay. I don't know something. There was issue in between. सब में से Zoom link एकदम से बंद हो गया सबका link
Correct.
automatically. मैंने directly फिर on कर दिया था meeting.
No problem. Anyway, that was the last slide.
Okay. हाँ.
I think
Thank
it
you
was
slide आ गया था. I could see that.
Yeah. Perfect. एक बारी पहले भी हुआ था पीछे ना, Zoom की प्रॉब्लम हो गई थी in one of the meetings actually.
Okay.
Suddenly then you had shifted to Google से या किसी के थ्रू किया था, हमने कुछ किया था. Thank you so
Right.
much.
Thank you, Dr. Navneet.
Yeah.
Thank you so much.
So with your permission, shall we close this meeting?
Yeah.
Okay.
Yes.
Okay. Thank you very much, ma'am. Thank you, sir.
Thank you.
So from here, I'm ending this meeting.
Yeah.
Thank you. Yeah.
Yes, sir.